Hi, welcome to the live forum session of the ASPER webinar titled The Impact of COVID-19 on our ART lab. Welcome to join us. This is Professor Ling, chairperson of SIG Embryology. Professor Arthur Chang, the co-chair of SIG Embryology, will be with me today to moderate today's forum. Hi, Professor Chang, would you like to say hi to everyone?
Yes. Hi, everyone. This is Arthur Chang from San Antonio, Texas. I'm really honored to be here to moderate and welcome two fantastic speakers, Dr. Novero and Dr. Pomeroy.
Okay, the two excellent speakers are here with us also, Dr. Novero and Dr. Pomeroy. Hi, Dr. Novero, thank you to be here with us. Would you like to say hi to everyone?
Yes, hello everyone. Good morning from Metro Manila. I'm honored to speak before the Aspire webinar here and we'll be looking forward to the discussions this morning.
Thanks so much, Dr. Novero. Hi, Dr. Pomeroy. Thank you very much for for your helpers and supporters from United States. Would you like to say something to everyone here?
Yes, thanks so much for the invitation, Professor Ling, as well as Aspire. It's an honor to be here. I'm coming to you from Colorado in the United States, and I think we're gonna have a really enjoyable time and discuss some important topics. So thanks for letting me be part of this.
Thanks so much, Dr. Pomeroy. And Dr. Novero and Dr. Pomeroy are going to discuss the topics and answer any questions we may have. Before starting the discussions, Dr. Novero and Dr. Pomeroy will give us a 5 minutes recap of their lectures. Let me start from Dr. Novero.
Yes, my pleasure, Professor Ling. So the topic was on the impact of COVID-19 on the reproductive system. This was the topic that would provide the background for discussing the impact of COVID-19 in the ART laboratory. So I thought that the more important questions to review for that topic would be, how is SARS-CoV-2 transmitted? And is it sexually transmissible? The virus, that is. And finally, the most important would be, is male or female fertility affected by SARS-CoV-2? Next, please. So the three basic ideas that we got from the talk would be, next please, is that ACE2 receptors and TMPSS2 protease or other cofactors are both required for cell entry of SARS-CoV-2 virus and its eventual replication. Now, we reviewed that both S2 receptors and the TMPRSS2 receptors are found all over. And especially ACE2 receptors are found in various organs. And we needed to point that out because the ACE2 receptor by itself, even before COVID came, was important in the RAAS system that converts angiotensin 2 to angiotensin 1-7, which have protective effects like vasodilation, anti-inflammation, antithrombosis, and antithrombosis. So with SARS-CoV-2 entering the cell, then it would prevent that conversion, and what would prevail would be the harmful effects of vasoconstriction, vascular permeability, fibrosis, and the like. Next, please. So the question would be, would there be sexual transmission of SARS-CoV-2? We review the evidence. There is no evidence of SARS-CoV-2 in vaginal fluid, but there is unconfirmed evidence that it can be found in semen, although the reports need to be reconfirmed. But remember that when you say sexual transmission, it does not only involve coitus. It also involves other body fluids which might be part of the intimacy. And we have already isolated the virus in nasal swabs, oropharyngeal swabs, the saliva, the anal swab, the urine, the tears, the breast, and the semen. So it's possible to have non-coital transmission and potential coital transmission also of the virus. So the answer is yes, it's possible to transmit the virus sexually. Next, please. And finally, is male or female fertility affected by SARS-CoV-2? Well, again, we needed to review the evidence, and there are tissue banks where they could be looked at and check the gene expressions. And in the studies that I reviewed, they found that they concluded that the risk of SARS-CoV-2 infection among males is high due to profound expression of ACE2 receptors and TMPRSS2, especially in the testes, so that the male reproductive system is susceptible to SARS-CoV-2 direct attack, causing testicular damage, potentially causing testicular damage and infertility. In the female, however, on review, there was sparse expression of ACE2 receptors and TMPRSS2 in major female organs, so that they concluded that it would probably not be susceptible to direct attack, but we should be careful about the effect on the female reproductive system of the systemic effects of COVID-19. So the potential infectivity of SARS-CoV-2 in the reproductive tissues should be considered seriously, especially in our management at the IVF laboratories. Professor Chiling?
Okay, sorry. Excellent. Thanks so much, Dr. Novero. And thanks again for your excellent lectures and excellent summary. So next, can Dr. Pomeroy give us a short summary also? Thank you,
Sure.
Dr. Pomeroy.
Thank you so much. That was a great quick explanation, Dr. Novero. I think when we look at whether there's the possibility of cells becoming infected with SARS-CoV-2, we have to understand there's various ways to determine that. One is to look and see if the virus is present. And so we look and we measure mRNA. A lot of times these studies are done with libraries that are they're digital libraries where they've taken single cells from tissues and they have amplified this library for mRNA, and you can go to it electronically and see whether or not the sequences of interest, say ACE2 receptor or BSG or any of the other enzymes like TMPRSS2 are present in those. You always have to wonder though, how pure were those single cell mRNA extractions, and were they contaminated also? You always have to keep that in mind. And the second way to look at it is you actually look and see whether or not the mRNA from the virus is found inside of the cell. And a third way is you actually use antibodies to some of these antigens like the ACE2 receptor in stained cells. And that hasn't been done as much. It's been done a little for the ACE2 receptor. When we take this information, we have to realize it's changing all the time. So what I have here may not be up to date. At the time when I put this together, I feel it was up to date, but there are new discoveries that we find every day or every week. And so I think it's important to understand these issues. So when you read about them, you can make a logical decision on what to do to safeguard your patients and yourselves from SARS-CoV-2. So if you look on this slide very briefly, I've looked at several reproductive tissues, and I've looked at whether virus has been detected. The only detection of virus that has been found so far was in the semen, and this was done by one group in China, and they were able to find SARS-CoV-2 in the semen. There was another group that looked, in fact, there were two other groups that looked at semen, and they did not find any SARS-CoV-2. But this could have to do with the time of infection and whether they had already recovered from the COVID infection. The other thing that's important is you have to have co-expression of a receptor. The ones that we know the most about are ACE2 and BSG, and the enzymes that cleave the spike. And by cleaving the spike, it allows the virus to get into the cell. And the most common one is TMPRSS2, although there's a couple of others that are called CTSLs. When we look at these in the ovary, there's a very low chance of infectivity because they're not able to find both of these in one cell type. Oocytes, and a great study that was done, I don't even know if it's published yet, but it was regarding two patients that went through IVF, and they were found right before they were aspirating the oocytes. They test the patients for SARS-CoV-2, and both patients had COVID. So what they then did is they collected these oocytes and the patients donated them to research. And when they examined these, they found out that the receptors were present in the oocyte, the ACE2 and the BSG, and they found CTSL, the enzyme, but these were very, they were not, some of these were not expressed very heavily, meaning they were only expressed in a few cells. So I think the chance of infectivity of oocytes is low. And one of the main things is no one's ever looked at whether the virus can bind the zona pellucida. And the zona pellucida is the shield for these oocytes that keeps many viruses out of the oocyte, keeps them from infecting the oocyte. If this virus cannot bind to the zona pellucida, then the techniques that we use of culturing, of fertilization, of transferring, vitrification, we do a lot of dilutions, and we would dilute out most of the virus. And then, as I mentioned, the testes of semen, it appears that there might be a chance in the male reproductive tract for infectivity from SARS-CoV-2. And in embryos, it does have co-expression of, at least in embryos that are around, I think it's 9 days, there's co-expression of the receptor and the enzyme in these blastocysts. So there is definitely a possibility for that embryo. Once again, we don't know about whether the virus, though, can penetrate the zona pellucida of these embryos. And that's why it's so important when we talk about designing methods to protect embryos and gametes from SARS-CoV-2, that we do many dilutions to try to protect and wash away any viruses if by chance SARS-CoV-2 cannot bind the zona pellucida. Next slide. We also need to look at we have a lot of data in the past that we can look at to determine whether or not a virus can infect a gamete or an embryo. And the biggest amount of data that we have is actually on livestock. And it has been almost impossible to use at least eggs, oocytes, and embryos as vectors for viral diseases. For semen, yes, and we have evidence of that. One of the best studies to look at to show that it's very difficult for these tissue to be used as vectors of diseases for whatever virus is a study by Anna Cobo in 2012. And she had patients that had high titers of Hep B, Hep C, or HIV. And she measured during IVF, tried to determine the concentration or the presence of these diseases in the follicular fluid, in the liquid nitrogen that was used for freezing them, in the fertilization fluid. And she looked at these fluids and she found no evidence using a very sensitive technique, PCR, of these viruses from these sick patients. Another study, a marvelous study that was done in mice, was by Kaiua et al. In 2003. And they also found no evidence of infection of mouse embryos. Next. So we know that or we can see at least that there's a very low probability of infection in these livestock species. And more than likely, then it means there's probably a low probability of infection in these human species also. So what can we do to reduce risk? I don't think there's any instructions of what you should do that I or anyone should be giving you. What should happen is we should offer potential solutions. And then depending on the risk that you see in your country, in your city, in your laboratory, you can choose to take action or not. We must be careful when we do this, that we don't bias what we do just because we really hope that this virus isn't going to affect human tissue. So I think one of the best things that I would do is if I was preparing sperm and semen for insemination or for IVF, I would look at some way to get rid of as much of the virus as possible. And this would be virus that is not binding the zona pellucida. 2 devices you can look at, because these haven't been approved for using in this method, but Nitacon has a device called the Pro Insert, and it is a device that will use inner column to make sure that the semen is not centrifuged with the sperm. And so you can remove the sperm from the bottom of a tube without contaminating it. The other is the new Zymo membrane method that uses no centrifugation in order to prepare sperm. Then I think for embryos, if we want to protect embryos, we may want to not do any assisted hatching or do any other sort of technology that will allow holes in the zona pellucida and potentially allow SARS-CoV-2 access to the tissue inside of the zona pellucida. So this means reduce or eliminate biopsies, potentially reduce or eliminate ICSI. For ova, I think we need to make sure when we're doing a procedure that we separate the oocyte from the follicular fluid and blood as quickly as possible, and that we isolate any ova that have cracked zona pellucidas, and that we keep those separate and keep track of those, and maybe try to transfer any that have had assisted hatching or that have hatched out. You know, we want to make sure we don't want our embryos to grow too long, or they'll hatch out and they'll defeat the whole purpose of not doing assisted hatching. But we could keep those separate and transfer those later once we have more information. Finally, for vitrification, I think the best way to handle vitrification in the lab, potential things that you can do is separate ones with cracked zona pellucidas from those that are intact, and make sure you use new liquid nitrogen for every vitrification. I think it's no longer a good practice to vitrify in liquid nitrogen one patient, bring over the next set of eggs or embryos, and vitrify them in that same liquid nitrogen. Finally, I think one of the biggest things we can use, and that we use all the time, is dilution. And we dilute out these our eggs and our embryos, and these dilutions are in 1 to 1 million range. And this is sufficient to remove most of the virus. I think that's it. Thank you very much.
Thank you very much, Dr. Pomeroy. Thanks so much for your excellent advice for the clinical practice. That's very useful for us. Thank you.
So this one from Stamford International. So we would like to ask Dr. Kim Pomeroy if we are trying to reduce LAH to avoid breaching the zona pellucida. The LAH means laser-assisted hatching. Do we avoid the lasering on the warm vitrified embryos blastocyst? How do we go about it on frozen embryo transfer?
That's a great question. I think it's fine to probably do the laser-assisted hatching on embryos that are warmed and you're going to transfer them, because you're basically taking them, you took them from the patient and you're putting them back in the patient. So I don't think there would be any harm done doing that, as long as you didn't go ahead and then refreeze those embryos. Now, one thing we do have to worry about is if a patient, let's say they are SARS-CoV-2 positive, we get embryos and we freeze them. Now, if that protection from their antibodies only last 2 years, and they then have those embryos that potentially have SARS-CoV-2 virus in them, could that cause infection of the patient once they've lost their immunity? And so you would want to worry about that. And you may, in the future, we may have recommendations that after being vaccinated, after so long, you should be revaccinated if you're going through a cycle like this. I listened to Dr. Fauci the other day from the United States, and he mentioned that even that people that have already had SARS-CoV-2 and have been diagnosed with the COVID infections, that his recommendation is that they still get vaccinated because it may protect longer. I can see that someone has asked a question about whether or not using an open device versus a closed device for vitrification, whether we should change because of this potential infection from the SARS-CoV-2 virus. And I'd like to answer that because I think that what we should remember about this is that the virus is going to be diluted out before it gets vitrified. In fact, one calculation that was done by Dr. Dave Battaglia was that there was like a 1 to 66 trillion dilution factor after you went through culture and vitrification. So the real purpose of using a open versus a closed isn't for inhibiting contamination, it's for inhibiting what's called cross-contamination. That means if that embryo happened to have the virus with it, that somehow when it was in the liquid nitrogen, it would swim or come out of the tube, contaminate the liquid nitrogen, and contaminate another specimen that was nearby. And I think that is highly unlikely. In fact, myself and a group of 6 people have a paper in Fertility and Sterility that discusses cross-contamination and talks about how unlikely that is. So I don't think you need to do that. And if you did change from, say, an open device to a closed device, then you're going to have a new learning curve on how to vitrify. And that can potentially cause you to destroy some oocytes if you're vitrifying those or embryos. So I wouldn't recommend it at this point.
Okay, here are questions for Dr. Lovera. And since we talk about the virus, can you give us some more detailed information about has the virus been isolated in semen or in seminal fluid? And also, does COVID-19 virus infection affect the male fertility? Can you give us more detailed information or update information about that? Since sounds like male reproductive system is more, we get more information about that. Sounds like cause our more attention.
That is correct. It seems that there are more studies on what happens to the male than the female, but I guess that's also because the men are more susceptible to SARS-CoV-2 compared to women. I think being male is a risk factor by itself for SARS-CoV-2. But just focusing on the question was, has SARS-CoV-2 been isolated in semen? Dr. Pomeroy already mentioned it, that there was only one study which confirmed the presence of SARS-CoV-2 in semen. That was the study by Professor Lee in China, and he was able to isolate 6 men, 6 samples of semen from 35 men, and they tested positive by PCR. And however, there were no other studies after that. There were studies there was this study by Pan, also from China, another study by Song, and then there were many more studies from Germany and also from the United Kingdom, where they tried to check the presence of SARS-CoV-2 in the seminal sample, but they did not isolate SARS-CoV-2. What some of those studies did show was that with the severity of the SARS-CoV infection of the man, there seemed to be a proportionate decline in the semen analysis. So those with asymptomatic or mild infections would not have any change in their semen. Those with moderate SARS-CoV infection would have significant impairment in their semen analysis. Now, going further, does SARS-CoV-2 infection affect male fertility? Well, again, based on the most recent reviews, most are saying that yes, the man's fertility seems to be susceptible to SARS-CoV-2 attack, but that's only potential risk. That is because of the isolation of, not the isolation, but the detection of increase of the expression of your ACE2 receptors and also your TMP RSS2 proteases in the samples of in the testis, and especially the presence of those receptors in the early stages of spermatogenesis. They also isolated a few from the kidneys, the prostate, and the seminal vesicles. So because of these, they thought that the man, as was mentioned also in the summary of Dr. Pomeroy, seems to have the propensity for or susceptibility for infection. And these authors began explaining what the possibilities are and how this can come about, meaning it would increase, because of the increased viral replication, it would affect. There are studies already that show that androgens will be decreased. It would also be affecting DNA fragmentation. Stress by itself, being in COVID and also receiving the antiviral drugs, would also affect the quality of sperm. So all of these together, put together, would suggest that male fertility is very, very susceptible to SARS-CoV-2 attack.
Thank you.
Thank you, Dr. Novero. And there's another question coming up. Is it necessary for us to store the frozen gametes and embryos of Brussels cysts and semen of a SARS-CoV-2 positive patient in a separate tank, which is meant for infectious sample? So this one probably Dr. Pomeroy can answer.
Yeah, this is an interesting question. You know, sometimes people have wondered, what should I do with my patients that do have certain diseases? Do they need to be stored in a separate container? So by regulation, they may not have to, but you have to ask yourself, what is good medical practice to do? I think one thing that's important is the differentiating between whether they are known SARS-CoV-2 infected patients or whether they're suspected. And as I mentioned earlier, there's a publication that I helped write that looked at this possibility of cross-contamination, because the real issue is, if I have this tissue that has the virus and put it in tissue that's virus-free, will it infect that other tissue? Now, if we look at what has happened in livestock for a long, long time, we have been storing embryos in the same tank, whether they're infected or not. In fact, a lot of these cattle were not necessarily tested, yet there are certain viral infections that are rampant in the livestock industry. And in no case has there been an example of where this caused infection of a herd. In fact, the method that is used by the International Embryo Transfer Society to freeze embryos from an infected cow is to do IVF and do dilutions, the same dilutions that we do now. They have one extra step that often they use, and that is that they put these embryos in trypsin to use the enzyme to eat away anything that might be on the periphery of the zona pellucida. It basically chews away a little of the zona pellucida. And then when you do the dilutions, you wash those viruses away. So if it was my practice, I probably would not necessarily think that I would need to store these separate. But because we don't know at this time, I would do it until we had more information. Store them separately. What that is going to mean is you're going to have a separate tank. But you may already have a tank that you set aside for using for patients that have antibody titers for some sexually transmitted diseases, or that have tested positive by PCR for certain sexually transmitted diseases. They could go into those tanks. I worry about a lot of this, though, is if cross-contamination is real, if it happens, which we have no evidence that it's ever occurred, why are we storing them all together? If I believe in cross-contamination, then why am I storing SARS-CoV-2 potentially contaminated embryos with HIV potentially contaminated embryos? So you have to figure out what you want to do. To me, it makes sense to store them now temporarily until we figure out whether it's a risk. And if we find out there is not a big risk to this, which there apparently isn't for HIV and for some of these other Hep B viruses, some of these other viruses, then they can probably store it with the patient specimen. I would label them separate though, for sure.
So just following this question, Dr. Pomeroy, do you suggest that we use vapor phase to store all the possible infected by COVID-19 virus embryos or blastocysts?
Great question. You can see I'm smiling because I didn't even think about that question, but it's a great question and I'm pretty opinionated on it. I think vapor phase storage, first of all, it hasn't been validated that it keeps cross-contamination from occurring. And probably most importantly, I don't believe cross-contamination can occur. I don't believe it happens in general. So those are two reasons. The other reason why I would not use a vapor storage system is thermally, it's less stable. Because we need to store these things at -130. And if they get warmer than that, then potentially we can damage them physically as ice crystals form, because they will form at about higher than -130. So I don't think that it's very safe for tissue to be stored. One of the biggest problems that we had in the United States was a clinic that had a vapor storage system, and the the solenoid that pumps the liquid nitrogen, it keeps a small amount of liquid nitrogen in the base of the tank. They're very large tanks. That solenoid gave out. When they recognized that the liquid nitrogen level was low, they then realized that the solenoid wasn't going to work, so they converted it into a liquid nitrogen tank by pouring a lot of liquid nitrogen. That ended up thawing out, and they lost many specimens because of it. So I think the safety of these devices has to be called into question, and it's mainly because they have so little liquid nitrogen in them that it's very easy for them to go dry.
Thank you.
But I do know a lot of people that use them. I know that there was one scientist, oh my goodness, his name slips me now, a very famous cryobiologist that spoke out, and he felt also that there was a lot of questions about the safety of using this equipment as far as regards the temperature is going to be very close to that -130. And it's very much going to be easier than for those tanks to go dry and potentially damage tissue.
Thank you. Very, very useful information.
I have a question actually myself for Dr. Novero. So I think that I haven't seen a lot of literature, and very few literature actually start working on this. So does the SARS-CoV-2, either the virus or COVID symptom, have some higher impact or confounding factor in certain subgroup of patients going through the fertility treatment, either the male or female patients? Will any subgroup got like impacted more severely than the others?
In the various literature which I have reviewed, the only study where there might be some mention of an increased propensity for SARS-CoV-2 because of a higher level of ACE2 and TMPRSS2 in the system are in a study by, I'm trying to get the name. Okay, yeah, the study by in Henarejos and Castillo, which was published in Fertility and Sterility. She studied the presence of ACE2 and MPRSS2 in the endometrium, and they found that they were quite low throughout in various stages of the cycle. However, when she tried to separate these according to age, they found a higher expression in the older age groups. So included in the abstract was a caution that probably older women undergoing fertility treatment might be at higher risk. So among the literature that I reviewed, I think that's the only one there. But if you couple it now with some basic things that we know, meaning those who are older, who are diabetic, who are hypertensive, and all the other comorbidities associated with increased risk, I think those should also be factored in. But generally speaking, all patients should be tested by PCR prior to treatment. So that should already be a screening or a safeguard prior to treatment.
So I have a question for Dr. Novero. Can I ask a question here?
Sure.
Please.
Thank you. So you mentioned we should be screening. So let's say I have a patient going through an IVF cycle and they test positive for SARS-CoV-2. What do I do? Do I have to cancel the cycle? What?
Most of the international bodies, and we do agree with it, that you should test for acute infection, which is PCR, which is the standard way of testing for it. And if it does test positive, the recommendation is to cancel the cycle. So there would actually be very few who would be going through an egg retrieval or egg retrieval process. So those that would probably test positive very close to the egg retrieval, and that the follicles are already 18, 20 millimeters, and you have no way of handling it but to retrieve them anyway. So those are the very few who should probably be allowed to undergo egg retrieval. And then I suppose the usual precautions can be done, and that's where we consider all those things that you mentioned about trying to make sure that with dilution and other techniques, you can mitigate the chance of the presence of SARS-CoV-2. But again, equating it with what we know from the literature, from what I mentioned a while ago, there would be a very, very low chance of getting the virus from the woman. Meaning when you do an egg retrieval, even in a SARS-CoV-2 positive woman, the chance of getting the virus in oocytes is quite low because of the low presence of receptors there. So even though we are saying it, however, I think still the recommendation is to not go on with cycles in case they test positive up to mid-cycle, but probably very late, I guess you have no choice but to retrieve them.
And I should add that one study that I mentioned that I don't think is published yet, but should be coming out soon, with the ladies, 2 late women that were collected, the oocytes were collected. When they tested those oocytes for SARS-CoV-2, the tests were all negative.
Yes. So what we were reporting, both of us, Dr. Pomeroy, what we were reporting that there seems to be a low probability of getting SARS-CoV-2 among women seems to be consistent until now. The risk is really also with a man. There's a higher risk with a man. So we need to really focus on testing the men who would be giving a sperm sample, or when you would be doing surgical retrieval for men.
And another similar question, what should we do if someone in the clinic is positive for SARS-CoV-2? That's a real tough question that I'm sure a lot of people have had to deal with in this at this time.
Yes, in our laboratory that happened twice. I was one of them, but I was asymptomatic. I was asymptomatic. So you have no choice but to isolate yourself and quarantine yourself for 2 weeks. Some would already, I think the protocol now is that you just need to complete the 10 to 14 day quarantine. If you're asymptomatic for 10 to 14 days, you're already essentially cleared. But in my case, I wanted to be sure. I wanted to make sure that I was COVID negative by PCR. So some would just go by time and the others would need to do a retest. So for in our case, lab people who are members of the staff who test positive would need to be isolated or would be on quarantine immediately.
Okay, I have a question.
Yes, go
Oh,
ahead.
go ahead. Yeah, I'm sorry. I have a question for Dr. Novero. It's about the embryo. So you mentioned that the embryo have a more chance, have the co-expression of the virus. So but it's not for sperm and oocyte. So then why embryo, the chance is higher, and where the chance come from?
Yes, that's a very interesting question. Well, the study that I presented where there seemed to be some increased expression of ACE2 and TMPRSS2 is in the embryo is because simply of the presence of the receptors. We're not talking about the presence of the virus. So it's only just the potential for infection. If I'm going to review if I'm going to mention some of the review data, they did mention that increased risk of the embryo to have viral infection. But again, I'm not sure. Dr. Pomeroy, have you come across studies? But I haven't seen studies where the embryo actually tested positive in where the man or the woman was positive and they did the IVF anyway and the embryo tested positive for a virus. I don't think I've seen a study like that yet.
I don't think there has been one, and it'd be rare if there was one. Who would give their embryos up to have them tested, because it would be a destructive test. So like you mentioned, the only study I've seen that really lets us believe that there may be a higher chance are these studies where they use these single cell libraries where they've collected embryonic cells and they're just looking at them to see whether they have the mRNA for either the receptors or the enzymes. And it takes both of those to cause an infection. And in the day 9 blastocysts, up until I think day 16 was what they tested, they were able to find a receptor and enzyme. So it means that they could be infected. But it could be that the zona pellucida is a good enough protection that they won't get infected. We don't know yet.
I have a question for Dr. Pomeroy. So it's about the disinfectant in the lab. So what would be your recommendation on the best choices of those, considering the effectiveness on killing the virus and also the low toxicity on the gametes and embryos? And also another question is, if if there's a breach happening in the lab, for example, a patient we did a semen analysis yesterday, then got reported positive, or one of our staff tested positive, would you recommend a deep cleaning on the bench and the whole lab, or is not necessary?
That's a difficult question, because we all know that any deep cleaning has the potential to produce a lot of volatile gases that could be toxic to the embryo. So we want to avoid that, but we want to avoid the virus too. I think the idea that you can catch an infection from the surface has not been proven yet for SARS-CoV-2. They've measured virus on surfaces and how long they appear to be exist on the surface. But existing on a surface doesn't mean they're infective either, because these PCR tests, they're not looking for the entire virus. They're looking for sections of the mRNA. And what may exist on some of those surfaces are chopped up pieces of mRNA that will never make a virus. If I was going to clean my lab, a lot of my decisions are based on what I've used in the past and what I don't like. I don't want something that's very volatile. So ethanol has never been allowed in my lab. No alcohol. I prefer hydrogen peroxide. So I would just get hydrogen peroxide from the store and use it out of the bottle and wipe it down, allow it to sit there for like 10 minutes, and then come back with a detergent. The best thing you can use on the virus almost is a detergent. So your other option is just find a very good detergent that doesn't have a lot of volatiles in it. There are some that have been tested to a certain extent to show that they're not very toxic to embryos. We have to be careful of those all the time, because really, I think everything can be toxic. It just depends on the concentration. You know, if we have too much water, we drown, but water isn't specifically toxic. So too much of anything can kill a cell or kill us. So I would use something like detergent. Use detergent, then maybe hydrogen peroxide is another thing to look at. Some of the others that are new, I wouldn't want to introduce something new into my laboratory that I wasn't very sure about. And what was your second question?
Oh yeah, actually the second
Oh,
question was
deep
about
cleaning.
Deep cleaning. Yeah.
Yeah, so I would be opposed to that if I had embryos in the incubator. You know, at one point we have to fight potential infection, but we have to realize it's potential at this point. The odds that it's going to somehow climb into our incubators and get through the oil and get into the media is very, very, very low. So what I would do is I would use something like detergent and wipe all the areas down with detergent as much as possible, follow with water, and that'd be the most that I would do. And that's usually what I've done in all of my labs. I only want things, for example, the floor only gets detergent. That's the only thing it ever gets.
Thank you, Dr. Pomeroy. Very good
Does
advice.
that make sense to you?
Yes, yeah. And also for the hydrogen peroxide, how much percentage do you use?
I use it as you get it out of the bottle. I'm trying to remember what that is. I think it's 30. Is it 30%, I think? Or is that the concentrated stuff? But I use it as you get it from the pharmacy, you know, at the drugstore, right out of the bottle. Mm-hmm. Maybe Dr. Novero knows, because I remember seeing the data at the very beginning on what concentration, minimum concentration for ethanol and minimum concentration for hydrogen peroxide, but I can't remember. And you do need to be careful with the hydrogen peroxide on some surfaces, though, because it's a strong oxidant. You know, if you have certain metals, it can chew them.
No, I don't have any specific information for the concentration of hydrogen peroxide. I do have a question, though, for you guys managing the laboratory. Most laboratories around here would be using a commercially available disinfectant. I'm not sure if we should mention the trade names, the brand names of those. I don't know if those are available in the US, but here in Asia, they can be purchased as the best disinfectants, commercially available disinfectants for IVF labs. We call them, well, not to mention the brand name, but they are ammonium quaternary compounds. And they market them as extremely safe, especially for use against viruses. I would like to know if they have already been tested specifically for coronavirus, because I'm sure they needed to show that it would work also for coronavirus, aside from the other known viruses.
Yeah, I'm not sure. I don't think anyone's really looked at them for coronavirus. I haven't seen anything on them, but I know what you're talking about. They're used quite a bit in many labs. And in fact, I think the one that you're talking about, there's actually been difficulty in getting it in enough quantity because a lot of people have been purchasing it because it's safe.
Yeah. Yeah. Yeah.
And I should mention,
yeah.
it's 3% hydrogen peroxide, not 30. Don't use 30.
Yeah. 30 would be expensive, I believe. Yeah.
Yeah, it would be very corrosive also.
Yeah.
Yeah. Here, I have a question for Dr. Pomeroy. So you mentioned that, trying to keep, since the zona has a protection function, so we're trying to avoid do the embryo biopsy, cysts and hatching, and even ICSI. So the first two procedures, like cysts and hatching, biopsy, is quite easy to understand. But for ICSI, they can have two sides, the procedures. One is ICSI is going to break the zona, but another way, since the sperm has a high chance to get infected by the virus. So for this purpose, it's safer to use ICSI instead of IVF. So what's your recommendation for that?
Yeah, someone's done some really good thinking there, because I believe they're right. If the man has SARS-CoV-2 in his semen, then it's probably best to put that semen through one of those systems like the Nitocon system or the Zymo system, and try to get most of that virus removed and dilute it out. And that's probably better than using ICSI, than putting what may be contaminated sperm in for IVF. So I understand that, and I think it all depends on who tested positive for SARS-CoV-2. If it was a woman, it might be best to not then go ahead and make a hole, although the sperm's going to make a hole too, but I don't think it'll be near as large as the ICSI needle will. I think it would be safer if a woman has SARS-CoV-2 to do it without ICSI.
May I comment on that too? Professor Chile?
I'm sorry?
Can I comment on that too? Just to
Sure, of course. Yeah.
just add on to the concept. I think it really starts with testing both the husband and wife to be PCR negative before proceeding. If they are PCR negative, then I think you don't have to worry too much about the ICSIs and the PGSs and the biopsies. Although, again, hypothetically, they will be more susceptible if they breach the zona. But I think you worry less if you are assured that the couple and also the embryologists and the clinicians who do the entire process are all negative. Now, the next problem would be if you will be dealing with them when they are already, when you have to do the procedures themselves, then I guess that's where that's where you need to do all your preventive mechanisms of diluting and doing your separation of your try to isolate the virus just to decrease the chance of the virus being there. What I'd like to propose though is this: what if during the middle of the cycle, and then the wife is confirmed to be negative, and then the husband tests positive, and you need to do the egg retrieval, of course. Would your options include just egg freezing, or would you still go on with the process of waiting through, sieving through even though I know you can also do PCR testing on the semen. That's another way of doing it, just to be sure. But those are the options that we can do. Probably we can have a discussion on those options.
Yeah, I think that, if the man tests positive, I think one of the easiest options you have is to vitrify the oocytes and address it when the patients then have immunity, and that way you're not doing something that's unknown. Who knows what happens? We do know that sperm. There is a really interesting study in mice looking at SV40 virus, and sperm can bind SV40 virus, and can take them into an oocyte after fertilization. So there is a potential that if there's enough virus that it can coat the sperm and that it may be able to get inside of the oocyte. So I would worry a little bit about that.
Yeah, the one more question here regarding the PCR testing. So how many testing both doctors recommend that we should to do before we use the oocyte, we retrieve the oocyte and use the semen? So just once, twice, the same day of retrieval or sample collection, or 2 days before?
I'll let Dr. Novero answer that one.
Okay. There are many protocols being implemented by different laboratories. Some would like to test even before the start of ovarian stimulation to save the patient from unnecessary expenditure for the cost of ovarian stimulation. But I guess the most important really would be as close as possible to egg retrieval. There are now very quick tests, even PCR tests, that come out in 3 or 4 hours. So that if you test 1 day before the egg retrieval, at least you are sure that the woman is negative. Same also for the man. As soon as he tests PCR negative, we personally suggest that they should collect sperm immediately and use only the sperm that has been collected close to the negative PCR test. I think those are the 2 ways that we've been trying to decrease the chance of having the virus coming into the picture of the IVF lab.
I think also if you look at the time of infectivity of a patient, I think we know something about that, although I don't. But let's say it's 14 days or 21 days, then I think that would mean you should test 21 days before IVF and then test on the day of IVF, and that should cover you. Do you know how many days infectivity lasts usually?
Yes, they're normal. Yes, they can be very infective up to 10 days if they're 10 to 14 days if they were symptomatic. However, I think you were right in knowing when to test, because they would need to be exposed to the virus for, say, they say that if you're already exposed to the virus for seven days, then 80% would already show that they are truly positive. So if there is exposure, a chance for exposure, I think you have to give them the incubation period before you test. However, if the woman has not been exposed anyway, I think testing them close to the egg retrieval within a few days would be safe.
I think also probably one of the most important things that physicians should be doing is they should be giving their patients ideas of what's going to happen if things go wrong and what the patient should do to avoid that. So for example, they should say, if your husband comes up with SARS-CoV-2 infection, then we will vitrify your eggs and we will have to make embryos later, and that might reduce your chances for a pregnancy. In order to avoid that, we recommend that you and your husband isolate during 14 days prior to retrieval or 20 days prior to retrieval, something like that. It may be difficult to do and the patient may not elect to do it, but I think you need to give them as much information as possible, because we know patients that will go to extremes to follow everything that you ask them to do.
To give you an example, just the other day, I had a patient where the man was given a report, presumptive positive. I said, what in the world is presumptive positive? It's not negative, it's not positive. So the infectious disease specialist said that there are possibilities. It might be positive for coronavirus, but it might be positive for a coronavirus, but not necessarily COVID-19 or SARS-CoV-2. And it's also possible it's in the waning stage. So I said, oh no, so what do I do? Do I cancel? Then the patient says, no, I will do my retest. And he retests, and after he had one negative test, and the IDS, the infectious disease specialist, agreed that they will need 2 negative tests, and he had a second one. So after 2 negative tests, after an initial presumptive test, they were cleared to do the IVF. So again, it's not only negative or positive, there are those in between that makes you nervous if you will be doing a test, a patient or not.
Okay, there another question for Dr. Pomeroy about the semen, the semen preparation. You mentioned trying do not spin down the semen. Yeah. So now, do you recommend do you have any recommendation about semen analysis, semen preparation during the pandemic? For example, do not do the try avoid spin down, and also trying to avoid swimming up directly from the semen sample. Oh, do you have a more detailed instruction about semen preparation?
Yeah, I think what we need to do is we need to think of it just like we would the oocyte. We want to get it out of the fluid as quickly as possible, but we don't want to sit around in it. We don't want to ever spin down sperm with the semen. Even with a gradient, I don't think that's the best thing to do, because then you have to go down through the gradient where you're contaminating whatever you're using to remove the sperm that's at the bottom. You never want to use a pellet though. So I would say the best procedure to use is to find a system that you don't have to centrifuge the semen. The Nitocon device is one system. You do centrifuge that, but you don't go down through the column of semen to grab the pellet at the bottom. So I think that's safer than doing a swim up or doing a general 2 or single layer preparation. And the second thing, like I said, no one's has tested these and done research to show that these are effective against viruses. But the Nitocon device is very similar to a device that was used in, or is still used in Italy and in some places in the US for men that are positive for HIV, to try to get sperm that are not contaminated with HIV. The second device is the Zymo device, and I don't have any interest in any of these companies, but the Zymo device, you just place the semen on what's like a little disc that has fluid in it, and it has to swim up through this filter-like device, and you can then pull off sperm that has no semen, and you do that without concentrating. Now, of course, you're leaving it in there longer, but I think it's still going to be better than centrifuging everything down together into a pellet or trying to go through one of the layers that has semen in it.
Okay, thank you. Thanks.
Sure.
I think it's 10 o'clock right now. I'm sorry, it's 11 o'clock right now. And yeah, it's time to close the session. Let we say, have any questions still we have? We just wait for 1 minute. If no more questions, we can close the discuss session.
And while we're waiting, maybe I can just say something. Dr. Novero, your insight has been really great, and it's really given me a lot more knowledge regarding some of the clinical issues with the SARS-CoV-2. So I appreciate your input into this and teaching me these things. Thank you very much.
Same thing, Dr. Pomeroy. I learned a lot also from handling on ways how to improve management of the laboratory here. Thank you.
Thank you both, and thanks, Arthur. Arthur, do you have more things wanted to say, Professor Chang?
Yes, yeah. Thanks for both speakers, Dr. Novero and Dr. Pomeroy. Yeah, I learned a lot from your insights from both the clinical and also laboratory sides. And also really appreciate Dr. Ling for organizing this. And yeah, you've been doing a lot of work and organizing this and moderating the questions. Yeah, I really appreciate it.
Thank you. Basically, thank you, Professor Chen. You did a lot to, trying to organize this webinar. And yeah, thanks. Sounds like no more question come up. So we're going to close the session soon. Thanks again for everyone joining us. And thanks again to the excellent two speakers, Dr. Novero and Dr. Pomeroy. I really learned a lot from both of you, really. And also I get a very useful recommendations and advice for my labs. So I really appreciate both of you's efforts and both of you's time. Thanks again. We're going to close now. In case anyone have more questions, just let us know. You can email you can send the email to the ASPER, or you can go to SIG Embryology's forum to post your questions, and we're going to follow you questions. And also, if you need, we can go back to ask help for both Dr. Novero and Dr. Pomeroy. So thanks again, everyone. Thanks again, both doctors, and thanks, Professor Chen. We close now. Have a nice day or nice evening. Bye now.
All right.